right, good afternoon, everyone. We are going to go ahead and start with this week's or this bi-weekly journal club. Today, we're going to talk about vaccines, variants, and as much as we can in the next hour. I want to start off by, of course, going through our agenda. We're going to start with the state of the state, which it feels like we haven't done that in a very long time. But I also want to go through some updates and information around what we know about the variants and some clinical updates that we actually in the last few weeks haven't touched upon. So starting with where we're at as like globally, we're over 106 million cases. If we look at where the United States is at, that is we're over 27 million cases, which is a number I keep tripping up on because it's just keeps growing, unfortunately. We have over 468 deaths that have been noted, and this was last updated this morning from the Johns Hopkins COVID resources. The good news is that we are seeing some changes and some declines in some of the infection rates and as well as hospitalizations. So this is a 7-day moving average of the data. So what we're seeing is that over the last 7 days, we've seen an average of 499 tests being done per 100,000 U.S. population, and then a positivity rate of 6.6%. We're also seeing that the daily confirmed cases has gone down to about 107,000 over the last 7 days. And in Florida, which we're sitting right, still over that higher than recommended positivity rate, but we are doing much better at 7.7% positivity rate. When we're looking at the ER trends, they are looking at both COVID, pneumonia, shortness of breath, and influenza-like illness. The COVID bar is really that purple, and I'm going to try to point it out for you, this little purple dotted line. So what we're looking at and seeing is that as over the past few weeks, we've seen a decline in cases for COVID. What worries me is that we still see a high number of cases of shortness of breath. As far as influenza, those cases have been down, and pneumonia has been down as well. So I'm wondering if those shortness of breath or maybe COVID that is not yet confirmed. Hopefully, we'll get more information on that. When we look, though, to the COVID tracking project, we're able to see that hospitalizations have gone down. Currently, we have 79,000 people currently hospitalized, even though this information shows the cases to be a little bit lower than what we just saw with the Johns Hopkins. It was last updated yesterday. So I trust that the hospitalization number is pretty much in line, and we're seeing that decline, which is a good thing. Unfortunately, we still see some the disparities that has plagued this pandemic. We are seeing more cases among American indigenous populations and Native Hawaiian populations, and unfortunately more deaths in those African-American populations as well as the indigenous population. When we look at Florida, we have over 1.7 million cases in the state of Florida. Our numbers have been going down when we look at the daily cases and daily positivity rates. So as of Monday, our daily positivity rate was 6.93%, which is improved from where we were at a few weeks back. You can see that in the end of January, our positivity rate was at 14.63%. And we don't know what's going to happen because we did just have a Super Bowl, and not sure where we're going to go and what we're going to see in the upcoming days to weeks. When we look at new cases per day, there was a small increase in the number from the 7th through the 8th, but nowhere near yet what we've seen back in January. So that is good news. And then Florida is collecting data that we've discussed on this call before from the long-term care facilities. So the positivity rate amongst residents is 1.47% and amongst staff is 0.94%. So that's all good news. When we look at what's happening with long-term care across the country, it's really good that the COVID tracking project has been doing a lot of good research and data collection on this. So in long-term care, we've seen 1.2 million total cases, a little over that. Unfortunately, though, even though long-term care makes up less than 1% of our population, we've seen 36% of the deaths in this population. So total deaths are over 161,000. The impact that this is having on our facilities is substantial, with over 32,000 facilities being impacted. And we are all experiencing and feeling that in some way. I wanted to talk about the variants. I think over the last 4 to 6 weeks, this has been something that's been in all of the headlines. A lot of information and research is now being conducted to look at this, and it's fascinating science to try to see a virus mutate like it has in the past few months. CDC is tracking all of this. We do see that the UK virus, which is B117, has over 900 cases. We have over 900 cases that is with that variant, and we're now seeing that in over 34 states. The B1351 is the South African variant, and we're going to talk about this a little bit more. We have 9 reported cases in the United States as of yesterday evening, and that's over 3 states. And then P1 is the Brazil variant, and we have 3 cases reported in the United States, and that's reporting in 2 states. When we look at this a little bit closer, so for the UK variant, we see that Florida is the one state with that 201 to 250 mark, and of the 690 cases, or actually now 932 cases, 343 of those cases are in Florida. And that number was updated this morning. So we are seeing a lot of spread here in this state. I'm curious and worried about what we're going to see after the events of the Super Bowl events and the parties that we saw, a lot of maskless parties this past weekend. And if you're a Super Bowl fan and a Buccaneers fan, congratulations. I am not, so it was a rough weekend. When we look at the South African variant, we're seeing that it's in 3 states, as we mentioned before, and for the Brazil variant in 2 states. You know, the question that I think has been asked of me quite a bit, and is like, what makes these variants so strong? Like, what is the issues that we're seeing? And I think a lot of that is being addressed. We see that being addressed in the COVID task force meetings that are now being broadcast 3 times a week, and the World Health Organization has also spoken about this. And there's a lot of great research, genomic sequencing research, and things that are happening at various universities, Johns Hopkins, Emory, various universities throughout the country. So as I was looking through this, when we're looking at the B117, that is the origins are in the UK. It's now in over 70 countries, and as stated previously, now in over 34 states. Which, as when I made this slide last night, it was 33. So the data is moving. The key mutations are noted there, and what I'll say about those, that the one that most of these variants have in common is N501Y, and that mutation helps the virus latch on more tightly to human cells. It is thought to be what is helping to make some of these variants more infectious. The other mutations, they range in what they do. They may help affected cells create new spike proteins. What we see with the South African variant, there's some other things that it may help bind more tightly to human cells. And there's a lot of commonality between the South African variant and the Brazil variant. There's also a variant that I've not heard about in the news very much. The variant name is CAL20C. That's a variant that was seen in California. It has a mutation that is thought to make it have an advantage when spreading. But we haven't seen that it has been more infectious like the UK variant. It has been located in the LA area and also, oddly enough, in Denmark. So I think they're doing more research to figure out what's really going on with that. The question that I think has kept me awake at night when I'm thinking about this is, what is the reinfection rates, and are those reinfection rates caused by the COVID variants? I was not made any more secure when about a week ago, Dr. Fauci said that the variants were most likely to become the dominant strains spreading in the United States, and that you could get reinfected if that variant becomes more dominant. Now, we have seen a lot of news, and I wanted to get into vaccinations because the biggest question has been, well, what is the impact of what we're seeing with the vaccinations that are out there? So just to review, I know all of us probably have this synced into our minds, and we know these vaccines like the back of our heads. But just to review, we know that there are two vaccines that are out in play right now that they have EUAs, and you may have already received either the Pfizer or the Moderna in your facilities, and we're actively using those. In the UK, they also have AstraZeneca out, and we'll talk more about AstraZeneca in a minute. But the thing that made a lot of news is the Johnson & Johnson vaccine, because what we're hoping to see approved at the end of the month is a single dose vaccination. And, there's been a lot of discussions about the efficacy of those two, that vaccination, because the initial report says 66% at preventing moderate to severe COVID with the 85% overall vaccine efficacy, which, I think because the other two vaccines that are on the market are at 95% after you receive a second dose, a lot of people were like, oh, well, that doesn't sound so good. But I think it sounds wonderful. It's pending approval, and we're going to talk a little bit more about that. It's an adenovirus-based vaccination, much like AstraZeneca. Novavax should be not too far behind as far as getting approval in the UK. I'm not clear on when it's going to be approved in the United States. Initial information said maybe Q1. But for any businessy folks, we're in Q1 and we're in February. So I'm thinking that might be Q2 or later. When we're looking at the difference between these, Pfizer requires cold storage, Moderna cold storage, Johnson & Johnson's and AstraZeneca are a different refrigeration process. So we're very hopeful about those viruses, those vaccines, rather, pardon me. I think even more so, this has probably created that whole shopping effect that you see some of your patients may have. It is interesting to see people saying, "Oh, I want this vaccine over that vaccine." I just think it's so interesting, and I don't know what I was expecting. We do live in the post Starbucks world where you can customize everything. I wanted to also highlight that there are other vaccines that are most likely not going to ever be approved in the United States. The Sputnik V is the Russia's vaccination vaccine, and there's a 91.4% efficacy. That is a adenovirus-based 2-dose vaccination. And then China has several vaccines that are out, much lower efficacies. When you look at the third option of Sinovac Biotech, that efficacy ranges depending on which trial in which country, which was just interesting to read. So I'm not sure of those two, and there needs to be more research done about what was happening with this Brazil variant, because in Brazil, I believe there are trials going on with all three of those vaccinations. So very curious to get some more information out of that area to figure out what's going on. I will also add that in African countries and in the Middle East countries, there are all sorts of trials going on with these three vaccines as well. So we learned a few days ago that there is a less efficacy in using AstraZeneca's vaccine on people who may have the South African variant. That was also combined with learning that the monoclonal antibodies may not work as well for this variant. So when we saw that there was a pause in vaccinating healthcare workers with AstraZeneca, it was quite alarming. They are doing more research, looking at doing more studies, trying to see if we need to do any, if there needs to be more boosters. But seeing that pause, and it was quite interesting. I want to flip the page to talk about what we're seeing in the United States. So COVID vaccines in the United States, there have been a total of, over 62 million delivered to the states. And what we've seen is that when we're looking at this, it is, the issue is that of those vaccines that have been delivered, we haven't seen consistent administration state to state. About 43 million plus vaccines have been administered. When you break that down, 32 million plus people have received one dose, and 9.8 million have received 2 doses. And looking at what's happening with the federal pharmacy partnership, we have seen that the total number of doses administered in long-term care facilities have been over 5 million, with over 3.8 million receiving 1 dose and 1.1 million receiving 2 doses, which is great. We still, though, see a lot of disparities when it comes to who's receiving the doses. And I've been thinking about this a lot, because I know that I live in Broward County, which is in South Florida. And I've been trying to get my father, my grandmother, and my aunts get them scheduled with a vaccine. And the interesting thing is the locations of where you could go is very far away from where they live. And I think we need to really think about that when we're thinking about how we are administering and where we are administering these vaccines. I was really happy to hear about Yankee Stadium in New York opening up, because that definitely helps. And in the conversations I've had about vaccine confidence and hesitancy, I wonder if we're talking enough about access. So That's me on the soapbox. Probably more to come later, but this is some interesting information from the CDC showing how few people of the indigenous people, Hispanic and Black individuals have not received that first dose, and even less received the second dose. So something that they're monitoring, and we should all be aware of. There's also when you're looking at who's received the first dose, and there wasn't a I think a lot of great logic in giving doses to healthcare workers first because of the fact that we're on the front line, we're doing a lot of different work. But I thought it was interesting to see that so many of our seniors in our highest risk population have not yet received that second dose. So that is something to keep track of. And I've been looking at this diagram from the Kaiser Family Foundation, where it really points out who of the seniors, which states are doing the best as far as vaccinating the seniors. And, that leads me to the question of which state is with the best vaccination rates, and it is West Virginia. So in talking about West Virginia's vaccine successes, they did a different approach than what we've done in Florida and a lot of other states have done. They really formed a collaboration with a lot of the local pharmacies. And I was listening to this story over the weekend, and I started reading about it and just looking up all of the West Virginia data. They've received a total of 380,000 vaccinations, maybe 380,000 vaccines were delivered. They've administered 327,000 plus vaccinations, with 219,000 of those being a first dose and 107,000 being a second dose. It is just really remarkable. And I'm wondering if that was some of the reasons and some of the logic that went into partnering with retail pharmacies, is seeing how well this collaboration has worked. In Florida, we've had a total of 2.7 million vaccinations delivered, with 2 million being the first dose and another 694,000, I believe, being the second dose. So, we still need to do a lot of things to catch up to and to use actually the supply that was sent to us, which I believe was over 4.2 million vaccines. When we look at where we sit in the world population as far as administering vaccines, Israel is doing the best. We fall very low down on the poll as far as vaccinating our people, and I'm hoping that as we now are going to see different corporations are trying to help, and the NFL offered all 30 of their stadiums to use as vaccine sites. I'm hopeful that we're going to be able to do more mass vaccinations. I also really am excited about the retail pharmacy program, and in looking at what that means for us in long-term care. The AMDA has recently put out a question, FAQ, actually, about those facilities who are giving the first dose of the vaccine at the third vaccination clinic. For the federal pharmacy partnership, the facilities were to have 3 vaccination clinics. You were hopefully to be vaccinating, given first shots at either the first or the second, and then that third clinic was really like for those second shots. And we are seeing that there are individuals who are receiving their first shot at the third clinic. And the question that was raised on the AMDA state task force just last week was, what should we be doing about that? The third, if a first shot is given at the third vaccine clinic. So there is some good guidance, I guess, that we received in from the CDC. And it is stating that, the long-term care facilities can work with the retail pharmacies, the long-term care pharmacies, if they are part of, like, are a COVID vaccine provider, can also administer that second dose. But there are some avenues for facilities to take if they find themselves in that situation. So I wanted to talk about just some updates. There was significant updates from the FDA on last week, Friday. We did see that they will be meeting to discuss the EUA and review everything for the Johnson & Johnson vaccination on February 26th. They also reported that there were risks associated with compounding remdesivir, and that they would caution against using remdesivir and that compounding remdesivir drug products. So there was some clarity on that, as well as clarity on using convalescent plasma. They want to limit the authorization to the use of high titer COVID-19 convalescent plasma for the treatment of hospitalized patients who have early disease. Those hospitalized patients who may have a poor immune response, that's where we should be targeting it. And so they clarified their position from the EUA that was approved back in August of 2020. We also, this study I wanted to just mention is about, there's been so much discussion about when should we be using monoclonal antibodies, and we're actually going to devote our next session to the discussion of monoclonal antibodies. I saw that the IDSA recommended against the routine use of certain monoclonal antibodies for outpatients for COVID-19 who may not be displaying symptoms, and was really stating that it should be for those high-risk patients. In this study, they looked at I'm going to butcher the name, but they looked at this antibody cocktail, and they really did find that it reduced viral load with a greater effect in patients with whose immune response had not yet been initiated or who had a high viral load at baseline. So there's the study and some of the guidance, it feels like it is in conflict. And I definitely wanted to bring in some experts. So that's going to be our next call to just talk about what we're seeing when we're administering this monoclonal antibodies, not only in outpatient settings where you're thinking about going to the fusion center, but how we could actively do this and do it well in our nursing facilities. This study about the antibody status and incidence of COVID in healthcare workers was also published in December 2020. And I think it really speaks to the big looming question about immunity, something that I keep hearing over and over again about, like, are you getting 30 days or 36 days, 40 days, 30 weeks of immunity? And it's really unclear. This study showed that the presence of anti-spike antibodies was associated with a reduced risk of COVID over 31 weeks after they followed up with these healthcare workers. So, I mean, that's a very positive sign. There is a lot of research still being done with this, and a lot of information, more information to come. With that, I'm going to open it up for discussion, and we could definitely take questions. And I have not been monitoring the chat because it is hard enough to project and present my screwy computer.
I do not have anything in the chat, so you're aware.
Okay. Do you have any comments or insights from anyone on the call?
Diane.
Yes.
Hi. I'd be interested to know if anyone on the call has been using any of the monoclonal antibodies in their facilities. In particular, BAM-LAM, and alternatives.
Hey, this is Maria. Can you hear me?
We can hear you.
Yeah. And yes, they've used them here in Florida. I know at a local near me, up in Palm Harbor, they just successfully infused. And it's really easy through Optum to get it, through the Optum pharmacy, to get the antibodies delivered. And it went really smoothly. The issue, the most troublesome issue is just that somebody has to sit there for the infusion and for an hour afterwards, I think. So it's kind of personnel heavy, but it was really successful. And she had improved symptoms, very mild symptoms, but she never got any worse. And she actually felt better within a couple of days. Everything went well.
Really great news.
That's the only personal experience I have with it, but I know that they're also using it. They've used it in other parts of Florida.
Yeah, and Dr. Kaplan, they are using it in, I know in the Tampa Bay area, the presenters who are going to come on to discuss are with Omnicare, and Rick Foley has provided us with quite a bit of information. So
right.
Definitely more to come,
Hi, this is Rich Frankhauser. I'm actually in Iowa. We've used it probably 20 times in our dementia unit. We had an outbreak in the dementia unit, and results were excellent. We didn't have any problems. There were 2 deaths from the unit. Both of those did not receive monoclonal antibodies. Some of the folks were close to hospice level, and they slipped through okay. So it has been interesting. We have one nurse that has provided all of the infusions. So I've been actually pretty excited about it in our COVID patients that have a lot of comorbidities.
Thank you. I see that we do have a question. Has anyone had any experience with the vaccination for people with a history of Guillain-Barré? I don't know if anyone on this call has had it, but I do know that, and I see that you put it in there, that the CDC was stating that the mRNA vaccine should be safe for use. We could ask around to see if anyone else has had that experience or had any patients who may have had a history of Guillain-Barré receive the vaccine for you. Any other comments or questions?
Diane, just a potential, I think a little tiny clarification addendum. Actually, ironically, the last article that you just had up, amazingly enough, I just got the current issue of New England Journal, and it's actually in the February 11th issue. The antibody status and incidence of SARS infection in healthcare workers, just if anybody's trying to locate that.
Yeah, and we'll put it up. And thank you, Dr. Kaplan. I don't remember how many articles I've read.
Oh, there's a million articles, obviously.
72 hours. So thank you for that.
The other, in passing, I just wanted to mention that I think many of us have seen that JAMA, this is not a testimonial for JAMA, but their viewpoint has had some nice little capsule summaries. And I would refer everyone to the online version. JAMA, January 28th, has a nice 2-page in viewpoint regarding the growing threat of viral variants. And there are about 7 suggested steps to address this at the end that are very simple, didactic, concise, etc. Thanks.
No problem. Dr. Kaplan, if you have that article, if you wouldn't mind sharing it, because we'll put it in our COVID library as well. I think I know which one you're referencing. So, there's a lot of literature, and I think there's a lot of information. So wherever you're getting your sources, it's always, there's just a lot of a wealth of information. The Annuals of Internal Medicine, the British Medical Journal. I really am in love with the Canadian Medical Association Journal as well. So there's a lot of good information out there. Yeah.
Definitely.
So I don't want to hold you guys if you have no questions, or if you have not thought of or formed the question, please do not hesitate to email us and ask. We will definitely look for the answers for you. And I thank you for attending.